Welcome to this session. This is something we've invented in Digital Europe to take advantage of the fact that we're in Spain. I think it's the first event that you've organized in a country outside Belgium, because Brussels is not a country, obviously. And in fact, it's the first time we've done something so large, combining so many different stakeholders for 2 whole days. And we wanted to take advantage of the fact that Spain, by nature, is the bridge between Europe and Latin America for many different reasons, or to start analyzing how we can identify the barriers we have for collaboration, not just on science, but in a more practical level. In companies, what are the recipes for formulas for success, and what are the barriers they're facing? In this regard, Digital Europe is going hand in hand with UNIR, which is the International University of La Rioja that has been operating in the United States and Latin America. I think it's the leading European university displayed across Latin America. Digital Europe has different working groups in digital health, and they conduct lobbying very much with the European Union so that we all have more business opportunities in digital health. And UNIR has a lot of experience in working in Latin America in the area of education. And I'm sure we have many speakers and attendees here, many speakers and guests who will or who write papers and research and conduct training and have the possibility of collaborating with our colleagues from Latin America. And here we're going to be analyzing their different experiences. What are their channels? What are their tools? What have they been doing until now? And how we can do this a little bit better. And for this, I'm going to welcome Daniel Burgos, who's the Vice-rector of International Research at UNIR, so he can chair this session. Daniel, you have the floor. Hello, good afternoon, everyone. Thank you very much, Jose. First of all, I would like to thank Casa de America. It's a wonderful venue. As you could see, one of the most beautiful buildings in Madrid, in my opinion, and we love working here. Secondly, we would like to thank all of the supporting team, audiovisual, media communications are doing a wonderful work to cover this. We've been working this for some time now, Digital Europe and UNIR. Since June, we've been organizing this, and the team's been paying a lot of attention to all the different details, and they always do a wonderful job. Today's afternoon session is going to focus a little bit more on Latin America and in Spain and Europe, and we'll see how we could combine all this in just 1 hour. So most of our speakers are only going to have time to say 3 or 4 things. And I'm certain they will say them very well. So we'll see how we can analyze, how we can work in this context of digital health. What's the format going to be like? We're going to start with a 15-minute lecture. It's going to be just a keynote presentation by someone that I'm about to introduce to you. And then we'll have a panel with 3 different panelists, each one specializing in a different area with experience in Latin America. And that will take about 1 hour and 50 minutes, so that then the session can be closed by the project coordinator who's hosting this event, Jose Martinez. And so that's what we're going to do. So the very first speaker, and the only one as such, as far as the keynote presentation, is Mr. Barreiro, who he's coming directly from the hospital. You just left your white coat. He rushed over here. He's a specialist in internal medicine, and he's specializing in tropical and infectious diseases and travelers' diseases from La Paz Hospital in Madrid. He's also a professor for some time now in the International University of La Rioja in the School of Health Science. You said that you have 100 and how many students in your master's? So for a highly specialized master, it's quite a significant number. I went on to spoil his lecture, but it's a very successful master. So Pablo, very welcome. The floor is yours. You have 15 minutes. Go ahead. Thank you very much. Thank you all very much for being here. Thank you to UNIR for organizing this event, also to Digital Europe for inviting me to speak to you. Very briefly, as quickly as I possibly could, because there's so much information I'd like to share with all of you, but I would like to share what my daily work is like in the fight against infectious diseases, where indeed there is the need to address issues on both sides of the Atlantic. We see travelers, tourists, migrants, people with infections that are imported from tropical countries or that are then developed in or that suffered in Europe. And I would like to share with you my experience on how digital tools can help us address this real challenge of infectious diseases nowadays. So as a visionary, the U.S. Surgeon General in the United States in the 60s predicted that we were going to end with infectious diseases. Unfortunately, his forecasting was not very accurate, and we could see all the epidemics that have emerged in countries around the world. Some are well known and some are newly emerging infections. What are the reasons for this? On a daily basis, I have faced the ones you could see here highlighted. They're actual real reasons. First of all, changes in the environment, climate change, deforestation, also changes in demographics, population movements, and risky sexual behaviors, intravenous drug use, immigration, tourism, and also the microorganisms adapt and change. They can get away from antibiotics, and it's making treatments more difficult. And medicine often leads to infections because of through different interventions on patients, we introduce infections into the patient's bodies, and also because the widespread use of immunosuppressants and also the indiscriminate use of antimicrobials that lead to resistance. So there are many different reasons to explain the emergence of so many infectious diseases. At a more graphical level, I'm going to show you the ones that I'm involved with almost on a daily basis, either from populations coming from tropical countries or also people living in Europe. For example, dengue. Dengue, it's a very well-known infection that's been transmitted by a mosquito, 4 different serotypes. Fortunately, now we have a vaccination, but it recurrently causes epidemic in tropical countries and recently in Latin America as well. Something similar to dengue is the chikungunya virus, also transmitted by mosquito. There's a horrible epidemic at the moment in Cuba, and we're seeing tourists, for example, who have gone there to that island, and they come back with quite significant symptoms. Yellow fever, also an infection transmitted by Aedes, and they could be prevented very efficiently with a vaccination, and it requires significant recommendation for travelers in certain countries, especially South America, and in particular Africa, where there are epidemics quite frequently. Malaria that was eradicated in most of the world, but in purple, there are places in Africa and the Amazon basin where it's still quite significant, and we all still have to recommend travelers going to those areas and sometimes treat people who come from those areas that could potentially be lethal if it's not properly treated and diagnosed. And of course, avian influenza right now It's in the news. We've already detected approximately 1,000 cases worldwide. It's a highly lethal influenza, fortunately cannot be easily transmitted between humans, and it can end up becoming an epidemic if it can more efficiently be transmitted between humans. In Europe, right now there's a new infectious emergency with 2 different viruses. The West Nile virus, which has been transferred from Africa to the United States at the beginning of the 21st century, and it's currently penetrating Europe. It's not a very severe disease, but people with certain baseline diseases, or if they're elderly or immunosuppressed, it could be quite lethal. We're more concerned, especially in Spain, where it's become endemic, the Crimea Congo hemorrhagic fever. It's a kind of Ebola that's transferred by and this is in the population of boars and deer in Spain. And we've already seen approximately 20 cases of infections in our and it's, like I said, transmitted by ticks with a very high mortality, up to 30%. Ebola, as you know, it was an emergency in the year 2014, 2016. There was a huge epidemic in Africa. We had a few cases in Europe, and we treated several people in my hospital. It's a disease which fortunately is not circulating across Europe, but we have other threats with similar viruses like Marburg virus. It's a quite significant epidemic in Ethiopia right now. And then I also want to talk about sexually transmitted infections that are increasing, both also in recent years, diseases that are well known in this case, but they had been practically forgotten, like syphilis, chlamydia, and so on. And in recent years, since the year 2000, we've seen that the incidence of these infections has been increasing. Of these kind of emergence of infections that had been forgotten, it includes smallpox. It's something that was eradicated thanks to the first vaccine, the most efficacious one of all. It had been eradicated worldwide in the 1980s, but now there's a reemergence of something called the zoonotic smallpox coming from rodents and primates, which has led to a huge epidemic from a mild pox, sexually transmitted in a risky population in many countries of Europe and North America, but now there's an even more dangerous emergence, also a zoonotic pox, but far more severe, with a different serotype. Number one, that it's growing in Africa, and it threatens to become similar to the one we managed to eradicate in the 20th century. And given the situation of emergence and reemergence of known diseases or newly emerging ones, what can digital health and medicine and tools based essentially now on AI at the moment? Well, we're already using some of the major or large databases that analyze all sorts of data. For example, medical data circulating in the internet and internet searches, Google searches, and social media interaction, information that appear in the news and the media. Just population movements. We just monitor, for example, mobile telephones, the use of private transport, airplanes, purchasing of drugs, also data on veterinary health, data about animals, and also we monitor the genetic remains of microorganisms in residual water or fecal waters coming from the cities. All of this information coming from so many different sources is integrated and analyzed with these AI databases, and it's capable of detecting the emergence of known diseases or even unknown diseases. These models have been validated by a company called Blue Dot that's a pioneer in these kind of analyses. And retrospectively, but that was demonstrated that this application would have been capable of detecting the first cases of COVID and the spread of COVID around the world with 1 or 2 weeks in advance. So these tools, and I said they're based on the analysis of big data or massive data, they're following up many of these diseases that I've been mentioning that can be very dangerous for a world population: COVID, yellow fever, polio, measles, meningococcal, dengue, influenza, etc. I think it's a very, very useful tool that can anticipate and allow us to be prepared for emerging infections. Also, very interesting, and we have some experience of this in Madrid, the wastewater analysis or screening coming from cities. Here, we have molecular biology technologies that are very sophisticated. We could detect genetic remains, DNAs of microorganisms or even bacteria, and monitoring this over time, we could see when there's a peak or surge of these microorganisms and thereby predict the emergence of epidemics. In the case of COVID, in this study, a Catalan group that collaborated with us was able to prove that by analyzing this wastewater, we could analyze the peaks of the curve of COVID with 1 or 2 weeks in advance. I think this is an extremely useful tool. Another matter that I'm very involved in is providing recommendations to travelers, people who visit countries with a specific risk in the tropics where there are more infections. There's a twofold interest in the travelers and the patients, and also public health interests, because when they come back, we need to prevent them from bringing these kind of infections. For example, there have been cases of Zika, dengue, and even malaria, but in certain European countries, in particular in summer, with the vector, the mosquito is circulating and they can transmit the disease. And the recommendations for travelers, there are many different tools that we use. Of course, we can't control everything that could happen regarding infectious diseases, especially with all these new emerging and re-emerging ones. We have to be fully up to date, and sometimes we have to make decisions in real time. But there are applications for travelers so that they can check themselves and see what risks there may be at their destinations and the countries they're going to be visiting, and also tools that I'm not going to go into details now, but that we use them in real time in our office, in our very desktop. And just to give you a few examples, this is a radar of infectious diseases. It's a Spanish initiative of the EO Foundation, very useful. On a daily basis, we receive in real time the emergence of epidemics and then cases of infections that are occurring all over the world. And we can analyze the risks for travelers, for example, if they travel, in this case, to India. So we can know whether it's necessary to take any necessary precautions. For example, if there's a risk of cholera, we could check that in real time. And there are endless possibilities with a worldwide coverage to detect these infections. As a matter of fact, there is access for some of these diseases that we're particularly interested in, like dengue or malaria. Here we can see the current situation of these diseases around the world. And we also have available the possibility to chat with these applications and ask them direct questions related to this traveler's medicine. So there are chat bots. For example, there's a tool that was developed in Italy that's very useful and very specific to answer questions. And we can also provide for the patient, in this case the traveler, personalized information. For example, if they're going to travel to Angola, they can take in their pocket the details about the most important risks and the measures that they must follow. So they're very useful tools to make decisions in a very short period of time. I also want to mention the risk of resistance in microorganisms, in particular resistance in bacteria to antibiotics. This is a real problem. We, every day at the Hospital of La Paz, infectious disease and epidemiologists get together to analyze what has occurred in the samples taken the day before in the blood, etc., and which bacteria are resistant, and to come up with a consensual agreement of the best antibiotic treatment to overcome the resistance and not to contribute further to this problem. We estimate that there are over 1 million people in the world right now that are dying due to infections that are resistant to antibiotics, and we think in the coming years this could be multiplied by 10. So it's a very, very severe problem. What can these digital medicine tools do for us? Well, we'll show you in a minute, but these are some of the reasons why we have this multi-resistant infections. The most important one is the indiscriminate use of antibiotics worldwide. I think this is the main reason, but not just in human medicine, but also in veterinary medicine. And that's probably where more of these resistances are being generated. And there are other significant causes, as you could see here. As I said, it's a problem that is widespread around the world. And as you could see, the multi-resistant germs, here are the ones that are causing the most problems, and they lead to mortality in patients. It's very, very high. Infections caused by these resistant germs are associated to mortality that's above 15% and even up to 70%. So it's a leading medical issue. Malaria, we're also detecting resistance problems to the only treatments currently available. The only treatments currently available for malaria. We can no longer use the famous chloroquine because the Plasmodium is totally resistant. Neither can we use mefloquine. We can only use systems based on combinations of artemisinin, and resistance is already emerging, particularly in Africa and Southeast Asia, to this drug that's essential to treat malaria. So what can we do? And how could we mitigate this problem to a certain extent thanks to digital medicine? Well, by improving the diagnosis of resistance. We test in particular the efficacy of antibiotics in most bacteria, but I'm not going to go into the details, but we could further these studies by using tools based on AI, monitoring and detecting in outbreaks or the emergence of bacteria that are resistant. Also based, as I said previously, in the analysis of big data, we can anticipate the emergence of these multi-resistant strains and also development of new antibiotics. This is an urgent need. We need new antibiotics. I would even dare say new families of antibiotics that address infections with different mechanisms to which the bacteria are not resistant yet. And AI is helping discover these new drugs. And here are some examples. The use of that personalized diagnosis based on artificial intelligence can reduce the misuse or abuse of antibiotics up to 30%. We're going to conduct an analysis that's going to tell us which is the best antibiotic without having to go using one that's excessively one of the last resort antibiotics. Also, detection of outbreaks with AI tools, and there are already 6 antibiotics that are being developed that were based on AI tools. And with this, I would like to show you what the landscape of infectious diseases is at the moment. For me, it's my everyday work. It's a reality, and I see it's urgent to resort to new strategies. And I believe, essentially, The ones based on digital tools can be very, very useful for this very difficult struggle. I could say that these tools will allow us to detect outbreaks early or in advance. They can help us use antibiotics better. They can help us detect resistance to antimicrobials. They can also help us develop new antibiotics, which is extremely necessary. And they can also help us, what's most important probably, achieve prevention. There is no better measure in infectious diseases in general medicine than avoiding them. But here, too, we can prevent, as we've seen in particular in the case of travelers, for example. There are still significant challenges ahead of us. I believe we need to still make huge efforts from all different areas, medicine and academia and science, to develop and incorporate these tools in our daily practice. They're going to be very, very useful, and also in research. And I believe in any case, we need to be enthusiastic and hopeful for these tools, but also cautious, because we need to have data on the validity of these tools before we incorporate them in a routine manner in our daily practice. So, in short, I think the situation is quite complicated at the moment regarding infectious diseases, but with tools that we hope in the very, very near future can be very useful. However, these tools, let's not forget, they're just here to help. They're never going to be replacing doctors. We will use the algorithms, but we will only trust what our experience tells us and our own analysis of the situation. So that's all I had to say. I wanted to give you this overview, and I'll take no more of your time.
Well, thank you very much. I don't know what to do, whether to go take a shower and, use plenty of soap to get rid of any viruses. Now, seriously, together with Pablo, we were saying now that we shall start the roundtable so that we can enjoy a more dynamic session with our 4 participants. So please allow me to introduce our 3 guest speakers who will join us now. Antonio Zimorra. Antonio, if you're so kind, please. He's the director of commissions at AMETIC and ALETI. He will tell us a little bit more about these institutions and what they do. The second is Diego San Jose Saras, professor of health sciences and specialist in preventive medicine and public health at the International University of La Rioja, UNIR. And Ms. Ana Maria Núñez Rubines, director of the master's degree in psychological intervention in crisis, emergencies, and disasters, also at UNIR. And also someone's asked me to give me a second. I had a little electronic post-it. If you don't mind, please. Oh, here it is. They are very long titles, right? I am also I've been working for the last 2 decades of the official School of Doctors at Galicia in the emergencies and coordinator of... Have you said it correctly? Yes, perfect. Okay. Welcome. You have the floor, dear colleagues. Right, I accept the round of applauses. I am, sorry, I didn't introduce myself. I'm Daniel Burgos, Vice-rector of International Research at UNIR and president also at the MIUCT University Miami in the U.S. Now, today's topic is Europe, Latin America, and digital health. So I will pose some questions so that we can warm up and improvise. I have some papers and some hints here that I will not be using. So let's flow. Ana, let's begin with you. I know that you're an expert on mental health. I guess this is one of the most tricky issues, more of a trending topic, let's say. And both diagnosis and treatment in crisis situation. And given cultural differences and scenarios, could you please tell us in a minute so that it's dynamic? How do you tackle such situations? Yes, as you see, we need to adapt to the culture of each of the population where emergencies are happening, of course. And obviously, it's not the same to intervene with local population here in Spain or working in Africa with Muslim population or other different cultures or religions. So yes, this is one of the topics we need to deal with within the sector of the psychology during crisis. We must be the ones adapting ourselves to the situations. And how do you go about? Do you do a sort of previous study? It's all to do with training. In this UNIR master's degree, we have contemplated a module tackling these cultural differences when we talk about mourning or suicide, important issues that are not understood or lived in the same manner in different ethnic groups. Or you were telling me, dear colleague, about your collaboration between AMETIC and Latin America. Antonio, how do you develop these links? And sure, AMETIC is an association covering the sector of digital companies in Spain, and together with our European colleagues, Digital Europe, of course, our organizers, and we also have a Latin American association, the ALETI, the IT association in Latin America. We are the founder because as technological providers, we understand that Latin America is a fundamental partner for us. We work in Europe, in Spain, in Latin America, and at the end of the day, digital health is crucial in the technological fabric where there's a myriad of companies, institutions, and both worldwide or even at regional sectors, we have a broad range and of offers with different interests, trying to develop different solutions, above all targeting digital health. Both at AMETIC in Spain, we also have a commission of digital health where we gather the main providers. We analyze the status quo of development, of care, social care, medicine, etc. And the One Health, as Dr. Barreiro mentioned, where we can include caring for our health, human health, but also the environment and veterinary health, because everything's interlinked, of course. And in ALETI, we also have a specific commission on digital health where we invite more than 20 countries, 20 AMETICs in the Latin American continent, where we share needs, suggestions, projects within the framework of digital health. Diego, you're a specialist on patient security. I understand, as with Anna mentioned, understanding the context is a must. Yes, of course. Well, before anything else, thank you very much for your kind invitation. And yes, the cultural context is fundamental when it comes to patients' security, particularly the field where I have been working on more in detail. Of course, security has to do with reduction of infections, reducing health incidents regarding patients' care. Everything that has to do with adverse effects or adverse events and patients' safety, of course. For our research group, the collaboration between Spain and Latin America when it comes to making visible these adverse events issues, and establishing common frameworks allow us to raise awareness and to work together with the WHO or other institutions, countries, etc., to reduce issues regarding patient safety and to improve care at all levels. Great. If we think about the motto of this Congress being digital health and incorporating new technology, this is nothing new, of course. Lately, we are overwhelmed with AI everywhere, aren't we? We could have titled it, AI and data even in your soup. We talk about it 24/7 in every single sector, pharma, agriculture, whatever. So I wonder, how can we survive while combining all these technological advance and patient safety, the work with the associations worldwide, Obviously, you shouldn't be overwhelmed with all these novelties. And as Professor Barreiro said, how do you tackle this? Any of you? Who would like to begin? When it comes to emergencies, really, this boom of digitization is a double-sided sword because, if something happens, a natural catastrophe, a terrorist attack, we feel bombarded with all this news. And all day long, night long, we are still being bombarded with the information. We are informed, but we are over-informed about it, which also creates some extra stress, mental issues on the population, even on some cases on the 9/11 attacks when we were all witnessing them live and we could see televisions worldwide. People actually felt phobia, fear to fly everywhere on the planet. And this social alarm was being spread everywhere. So it's true that on the one hand, it gives us plenty of tools and it's really useful. But on the other, we need to beware the damage we could cause with some mental issues. Well, I think it's a facilitator, and we can develop some activities when it comes to the health sector, is something very necessary when it comes to care and looking after the population in general and managing our resources. Without technology, these days, we wouldn't be able to respond to the general population needs in the different sectors, of course. And let's remember that technologies help us to develop services anywhere where they are needed. It's more and more useful not to need to have the patient lying on a bed next to you in a hospital. They could be far away, thousands of kilometers, and we could be intervening that patient remotely. And this is something we need to make the most of. I am a telecom engineer, and I'm not a health expert. But given my experience, well, of course, I've been working on this for 3 decades, and for me, it's natural to talk about this every single day. I see new technologies beginning. Future is being born today, but also tomorrow and the next day. Our sector has an infinite capacity of evolving constantly. I'm not talking about sci-fi, what's going to happen in 50 years' time. I'm thinking about the fact that we don't really know what's going to happen in 2 years' time, as we didn't know 2 years ago that today we would be capable of doing what we do. So I humbly suggest, to see the kind aspect of being a necessary companion. Without these technologies, we would not be able to do thousands of things, also in the health sector, of course. As for patient safety, what it has to do with measuring data, improving and digitization of clinical records, etc. This has really helped us to statistically control plenty of processes. And it's true that from that standpoint, it's tricky because we have plenty of challenges. We have new forms of customer care, formulas of in-house care or domicile care, and some more challenges that could be related. And we need to think about how these affect the quality that our patients receive. We need to be proactive when it comes to how we use new technologies. And it's okay to implement them, to use them, of course, but we should always keep focus on how we are doing this, and obviously to avoid adverse events in the future, of course. I remember a Cuban intellectual working in Mexico, and recently I was talking to this colleague, and he was saying the exponential world. And I wonder, as for technology, again, the same thing happens. Like Moore's theory saying that we got to change technology every 6 months, 2 months, but now every week, every 10 days. These emergent technologies are today, and yesterday's are obsolete. So this affects us because people feel collapsed, overwhelmed. You know, I'm also a technical person, but one day I'm going to say I'm fed up. I don't want to keep learning. This is far too much. And the human touch, this is what I want to be talking about. When you talk about with people who are not working on the health sector or technological one, and suddenly you need to face together with them a situation that requires this exponential process, this crisis situation, or when you want to incorporate new technologies or digital tools to the health sector, then you need to walk hand in hand. And this can be complex. I guess this is part of your life in your clinical practice, this human expert together with technology. Do you feel that it's really important? How do you deal with these human technological combination, let's say? Well, as for patient care, of course, we are seeing that the technological development is increasing exponentially, and with specific patients, the elderly ones, being chronically ill, with this elderly, older population, sometimes we have not been developing these tools, thinking about them, and surely this is something we will need to consider when it comes to implementing some new forms of care, new protocols. And this is a challenge. We got to take this into consideration, not to forget the patient's standpoint, and we need to adapt ourselves to their needs. Anna, in your case, I just wanted to mention that challenge we're talking about. I mean, let's not forget the main topic of this session. I mean, the potential collaboration between Europe and Latin America. We are talking about a broad topic with very diverse scenarios, and precisely health staff and the whole health system and patients, we all have very different circumstances. So one of the major challenges in this process of collaboration between Europe and Latin America is precisely to see how we can coordinate everything, especially from here in the European Union. We have some common aspects as for legislation, political context, etc. However, in Latin America, it's not the case. There are some initiatives trying to unify certain things to keep advancing. If we have more time, I can share some more information about this. Thank you. Yes, good point. Ana Maria, I meant to ask you, As the master's degree manager, how do you teach new students to help patients not to despair with all this myriad of tech? Yes, of course, the skills that an emergency psychologist needs to have, of course, are being taught. After the pandemic, it was a must. We all had to adapt ourselves to new technologies because precisely during lockdown, we had patients and emergency situations were happening, and we just had to help such patients online. So we have incorporated these tools, and they are useful, of course. And does this happen? Can you help patients in Peru, Mexico, across the Atlantic? Yes, sometimes when we have patients that, due to certain reasons, they need to travel to different countries, yes, we help them. We have the RIPE, the Emergency Psychologists Network in Latin America, which main goal is specifically to share all these know-how experiences in Latin America. They are in Peru, Brazil, Mexico, and then Spain, Portugal, and Europe is also represented via the EFPA, the European Federation of Psychologists Associations. Right, wonderful. Now I'll give the floor to our dear attendees to feel free to ask. If you let me, please, in 5 minutes' time, you'll be able to ask whatever you like. But one last question, okay? If you don't, I have plenty of questions, but I think it's more interesting for you to be able to participate. Antonio, let's delve into the Latin American health scenario. Are you implementing some sort of action? Do you have some sort of working group, or are you somehow linking through AMETIC or ALETI regarding digital health? Could you please tell us a little bit more about this? Yes, through ALETI we have a committee on digital health, which is led by the specialist from Costa Rica, and also some entities that are providing technological tools for the health sector. In ALETI, we are 22 countries represented, and precisely our main goal is to foster initiatives and share common projects and proposals. Before I was mentioning that in Europe we have some common governance and legislation, and it's not so much the case in Latin America. But in the digital sector, for the health one, we have some success stories, EBECA, CELETI in Spain, and also some other global initiatives from the Development Ibero-American Bank, from the WHS. There's an interministerial health commission fostering common development policies. Afterwards, I can tell you a little bit more in detail if you want. And now we are worrying about the standardization of data so that health data are all following the very same standards as we're doing already in Europe. In Latin America, there are several initiatives willing to promote this new standard, and plenty of these programs, they want to develop some aspects of the digital health in one country or another, but maybe in fora like this one, what we could be promoting is the initiatives to help collaboration between countries, not so much to foster specific national projects. If it's an intercontinental collaboration, all the better. Diego, I believe that you have also been specializing on chronic illnesses and aging. My question is, could you please tell us a little bit more about this and above all the potential differences or the similarities between cultures when we talk about patient safety in Europe or in Latin America, how the elderly are cared for, etc.? Can we establish a certain comparison? Well, I can briefly tell you about my studies. I work at the Ramón y Cajal University Hospital, and at the preventive unit, we are establishing some projects together with some elderly homes. This is a pioneer project that enables us to get closer to these developing strategies on the prevention of infections and improvement of care for the elderly. This pilot project that we've launched from our hospital, hoping that we can replicate it to the rest of the autonomous, to the region, to our community, whether this confirms the positive results, we shall be able to implement it nationally. However, the problem that we're facing, and this is going to respond to the series of difficulties we're facing if we want to export this to Latin America, in Madrid, in our community, you can find elderly homes which are very different in the sense that they are highly technical, and some other examples of nursing homes where technology is not a big thing. And this is only Madrid, but imagine if we think all around Spain, in Catalonia, where we have the social health, long stay, day hospitals versus nursing homes, we see that it's going to be very, very different throughout Spain. So I wonder what sort of taxonomy should we be looking for when we want to export this to Europe? HALT 4 being the main study done on long-term stay facilities on infections. We have residential homes that should be easier to the elderly's homes, but then in the U.S. we talk about nursing homes. So the definition is not crystal clear. If we extrapolate this to Latin America, we find more differences yet. So this is a challenge we got to face. We need to make even more visible how we define and think care in the last stage of life with patients that are highly dependent or suffer chronic pathologies. So we could define more macro processes for a top-down effect to the micro level and adapt it to Colombia, Ecuador, Mexico. It's never homogeneous, so we will need to adapt ourselves. This will be a major work, but first of all, we need to raise awareness at the level of decision makers, policy makers, people defining those national health policies. I will be asking a couple of questions, if you allow me. If there's an emergency and you send a team of psychologists and specialists, do they also need treatment afterwards? Do they need to somehow... Are you using technology to help them, or is it sort of tete-a-tete or one-to-one sessions? Sometimes we do use some technology, and it's true that when we do our briefing and preparation work before the intervention, we work on personal care, personal protection. During the emergency, of course, self-care is fundamental, and then we support each other. In the post-emergency phase, of course, we can feel I'm thinking of the Alvia train crash. All of us had a friend or a child victim, and if you were a dad or a mom, of course, you felt affected, highly affected. So there's a team of psychologists who also remotely offer this follow-up, and in case that we are also affected by the emergencies. Okay. Please allow me, Pablo, Professor Barreiro, if you take a seat again so that you can be part of our panel. First of all, I'll give you the floor because I said you were going to mention something about the exponential development of technology. Well, thank you very much for your participation. I have clearly seen how the 4 fundamental elements in this fight against the myriad of infectious diseases, the clinical epidemiologists, the technical, and the human expert psychology. I think this is crucial. At the UNED, I am lucky enough to participate in one of the bioethics masters with a high level of impact. And this is crucial because when we tackle infectious diseases, we got to balance, on the one hand, individual solutions and public health measures, which also affect the individual, as you said correctly. So we got to consider 4 pillars here. The first one being always keeping on the quest towards the common well-being, and health authorities should be developing prevention mechanisms, but counting on each and one of every single member being part of it. So this search for the common well-being should also consider the good practice in the sense of implementing justified and well-argumented, solid and scientifically proven measures so that the population can adhere voluntarily to all these, so that they don't feel bombarded or compelled to do so. And equity, we've got to adopt such measures. We cannot do the same with the elderly population, with children, with toddlers, etc., or with women or some people from certain ethnic groups or another. And lastly, communication. I believe that we could follow up the series of measures that we are adopting and communicate them to the population so that they understand that this sacrifice they're being asked for is well worth it, whether we are all on the right boat or not, or whether we should change the strategy. And so how do we deal with all these elements? I believe that during the pandemic, all of us have suffered these 4 pillars, these 4 elements ourselves, and we have understood how these measures had been sufficiently adapted to each of the population, whether everybody had been well informed or whether we were being manipulated, maybe. I mean, these human aspects of medicine, public medicine, are also need to be considered regarding the monitoring of infection diseases. These 4 elements are fundamental.
Great. Thank you very much. Any questions from the audience? Any participant? We have 4 experts here, but as Pablo said, we have 4 different experts specializing in different areas. Please wait for the microphone so that we can hear you online and the rest of the world, and you become famous. Gonzalez from European Patient Advocacy Institute, but originally from Venezuela. I have a question for Dr. Pablo. Really interesting, all this information about infectious diseases, but my question is the following. Maybe it's not directly related, but haven't you included infectious diseases like Chagas that have been a huge problem in Latin America and Europe and the United States? And because it's silent, it's not being seen, it's not being tested or monitored. And it's a big problem that for many years now is affecting people and employment because it leads to significant cardiovascular disease. Is there any follow-up that you're conducting in this regard? Yes, it's a fantastic question. Thank you very much. I was focusing more on infectious emergence And we're talking more about a latent and chronic disease. We also have to be very sensitive to detect these populations with these kind of infections that are less apparent, so to speak. And Chaga is one of these wonderful examples. And also HTLV disease we monitor very closely, and other infections like chronic parasitic diseases. And we're very, very sensitive to all of this in our unit, or all these infections. But we're developing programs to follow up these diseases among the general population, and to include in the screening of diseases, detection of these diseases as well. For example, in Spain, there's screening done in Chagas infections in blood donors. And we've also included, we just had a session a few weeks ago, also the detection of HTLV in pregnant women coming from risk areas, and from the migrants coming, especially from Africa, under terrible human circumstances. We have an agreement with the social services so that everyone arriving under these conditions is studied by us to detect tuberculosis, syphilis, and chronic parasitic diseases such as schistosomiasis, etc. Excellent question. We still have to be monitoring these infections that are less apparent, but they could be even more impairing and lethal. Thank you for the question. Any more questions from the audience? Go ahead, please. Please wait to have the microphone. Hello. For Pablo as well. I am Daniela. I'm a psychiatrist currently working. I loved your presentation. I wanted to ask you if these tools that you've presented, are some of them already being used to make clinical decisions? And if so, what was the process of choosing the tool and incorporating it into the technical workflow? And if not, why do you think that is? Why are so many of these tools only used in the pilot phase? That's our experience in psychiatry, at least. I think that's one of the big challenges, having a validation, a technical scientific validation of all these tools based on artificial intelligence. I think at a user level still, we have no guarantee that the information coming from AI can be fully applied. There are certain tools for microbiology that have been validated by the company that manufactures them. For example, the one that I mentioned, but at the clinical level, well, we use many of these tools on the desktop, but we always, obviously, following our own criteria. They're just tools for assistance, but of course, the ultimate decision on the therapy or diagnosis is never up to the tool. But I use a lot of these tools on a daily basis for queries, just to fine-tune my criteria. But for a diagnostic tool, yes, we already have a system where, for example, if we see X-rays or scan or CT scan slices, the AI will mark certain areas of interest that you may have gone unnoticed. But AI is being very helpful in this regard, but obviously it's always a support, but you always need to validate it as a human being. I think never, especially not in medicine, we should never allow machines to make decisions. Thank you, Pablo. I really like you to insist on this because it's a very similar approach to the one we follow in education. We at UNIR work on personalized learning for many years now. Now there's, the emergence of generative AI. Although similar things have been working for a long time, it sounds like ChatGPT is the only thing that exists now. But the truth is that similar machines have been been existing for a long, long time, and we've been using them for a long time, thinking about personalized teaching, learning, and so on. And it should always be semi or pseudo-automatic, never fully automatic. The final decision should be mine because, if they take away my ability to make the final decision, then my job is pointless. So machines are helpful, but the final decision needs to be made by humans. I think we're all in favor of using tools, but in the end, I'm the one pressing the red button. No one else will do it. That's the idea. I want to ask you something. A few days ago, you sent me a very interesting email where you're talking about the use of AI. In certain cases, it's not so efficacious. And you were talking about stress situations or where the agony or anxiety of certain patient through a tool and saying, talk to so-and-so. It's not fully efficacious in your opinion. Could you talk a little bit more about this? Yes, as I said earlier, it's a double-edged sword. It can be helpful at times, but if we don't use it properly, it could be counterproductive. For example, now they're talking about, reviving people who have died. When we are working in emergency, they're usually traumatic deaths, and very often you can't say goodbye to the body because you really cannot see the body. Artificial intelligence, when they bring that dear one close to us again, can help us say goodbye to them. So so that we can make progress in our grief, but we run the risk of having the person denying their mourning and the death, and the pain or the grief becomes chronic. So it's always a double-edged sword. It can be helpful, but if we don't use it properly, as I said previously, it can be even counterproductive. And once again, the key is yourselves as professionals and the patient. It has to be a human key that provides common sense. Yeah, exactly. And the use, above all, based on ethical criteria of what we're doing. Thank you. Great. Antonio, I think you have a very significant success story on the use of data in health and collaboration between Europe and Latin America. Can you talk a little bit more about this? Yeah, of course. Europe, and in particular Spain, is full of success stories regarding health in general, not just digital health, but we have a highly developed system that I believe can be one of the reasons or enablers for this collaboration between continents, Europe, Latin America. There has to be based on a reason we can collaborate, but on which projects. And European data health space that has just been regulation has been approved for this, and this could be one of the cases that could be used to promote this collaboration in between Europe and Latin America. I was saying that Europe is very well positioned in this area. I was talking also about standards. In Europe, there's a very clear standard that's already been approved. But Spain also has very good success cases. First of all, a health system. I'm not just talking about health, but also health. But we have a health system that can be used as a benchmark worldwide, and it could be used as a benchmark for these international collaborations. We could provide endless cases. Dr. Barreiro was just mentioning some of them that were really unique. But I would say, for example, the electronic health record, it's a mega project for information with the use of technologies. We can have data that are very useful. First, among the 17 regions in Spain. We're talking about collaboration between countries, but let's not forget that this collaboration is an interaction is very necessary between the different regions in Spain. And also we could talk about the social records, electronic social records of citizens. In other words, what are the benefits they're receiving from the government? And in this, all this collaboration between countries and continents, Spain can play a leading or a unique role for many different reasons, for cultural reasons, for the proximity, because of the language that they share with Latin America, and also because they're role models in the area of digital health. We're role models worldwide because of the interoperability of our systems. I was mentioning the 17 regions in Spain and also telemedicine. We have a telemedicine system that's one of the on the leading edge worldwide, and also the qualifications of our healthcare professionals. It's one of the challenges that we face in any system, and it's absolutely essential. It could become a bottleneck. And here, training, although there's still a lot of work to be done, but I don't want to exaggerate this area, but it could be a good example of best practices, how the ecosystem and the healthcare professionals in Spain have sufficient knowledge to use technologies the best way possible. Thank you very much, Antonio. Any more questions from the floor? Go ahead, Fernando. Thank you. I want to ask Diego, I don't want to talk about just my area, but in your unit, you've pioneered implementation of certain digital tools that I'm familiar with and that we've discussed in the past, and some very successfully and with a lot of recognition and awards in the health sector. But I'd like to hear you talk about vaccines, adequas, and all that, the acceptance of all these tools. Could you talk about how these digital tools have been accepted and implemented? Thank you for the question. Indeed, Paloma previously talked about some of them. She's a clear example within the hospital of how she's developed this dashboard for multi-resistance surveillance and the issuing of reports for the various units. All of these initiatives at the beginning, well, I'm going to differentiate between the various initiatives. On the one hand, the applications that we've developed at ECHO is one of them, which started very strongly when we started disseminating. Then there's a plateau moment where they're become sort of outmoded, and then there are certain peaks afterwards where people start downloading them and they start asking questions again. For example, in the case of the Ethereum application, they've even come up with corrections that they've recommended afterwards. But what I can say that in the case with what we're currently doing with nursing homes, we've developed an application that collects data from the electronic health record, and we make use of that digitalization to come up with dashboards with different indicators that could be useful to follow up different matters. In a particular case, in a very specific case, hospitalization due to adverse events that originated in nursing homes allow very visually professionals to see who are not used to receiving these indicators, and they can very visually see the burden of certain causes for hospitalization or multi-resistant microorganisms. And eventually this keeps progressing, and the acceptance has been very positive. And the only thing is that obviously we need to maintain it and continue, because it's the path towards raising awareness among the health professionals regarding these topics. You could come up with a spin-off. Emetic is here, so it can help you come up with a spin-off of your applications, because the truth is I'm familiar with them and I've been very fortunate to be able to use them. Anyone can download them, and if you want to later on, you can download them from the App Store. They're fantastic, and I really do think they should be used more frequently. It's true that you're doctors, you're not entrepreneurs, but I think, we really should use them more. More questions, please. This is a second question for you. I don't know if this is possible. Just kidding. If no one else is asking questions. Going back to Antonio and Ana, could you delve a little bit more into the interaction with Latin America regarding technology? What are the transfers like? How much has it helped? Because the systems are totally different regarding healthcare. So, Ana, the support from psychiatrists in these kind of emergencies, are there any transfers from here to Latin America? Any preparation of local psychologists in Latin America so that they can help locally and not just here in Spain? Well, in our setting, there is a Ibero-American network of emergency psychology that includes institutions from Latin America and from Spain, and they establish synergies to share knowledge. Throughout the year, we conduct lots of training with participants from both sides, and we share a lot of knowledge. And also, we issue newsletters that are circulated across the areas. That's what we're working on, rather than direct care from here to Latin America. But we do have training, and during the year, a lot is delivered. I would like to add, when you asked how we've done it, I wouldn't say it's something that's already been done, but rather it's something that we're still working on. What we're trying to do is bring together the two ecosystems, healthcare and technology. And this is one of the key tasks that we're carrying out. From any of the technological association, we could talk about Digital Europe, it's absolutely essential to bring together both ecosystems so that technologies really are serving the professionals who need them. Digital health should not be understood as a technological matter, but rather as a transformation. It's the enabler so that health services become global. As I said previously, in the field of technology, things change very dynamically. And in a couple of years, it will be relatively different. And in 5 years, it will be very, very different. So more and more frequently, we're going to be seeing applications and solutions for healthcare that are global. So telemedicine won't matter whether it comes from a region in Spain to another, or a European country to another one, or a European country to a Latin American country, or from a Latin American country to a European country. This is going to be happening more and more frequently in the future. And what do we need to do for these collaborative projects? Well, first of all, I'm not referring so much to technology, not even in the ecosystem of health, but I'm talking more about politics. We have to have state agreements between countries or a continent so that we have projects to develop health or health development projects, and come up with different collaboration initiatives where Europe is very well positioned. But in this particular case, regarding the technological needs are shared in healthcare, we have a very good level of development. And something else which I haven't mentioned, where we're well developed in Europe, for better or worse, is regarding regulations, which is also very important. So that application of these technologies in all of this context, it's very important to make sure that the regulation is well developed and sound. And here, in this regard, in Europe, we're also a role model. Thank you very, very much, Antonio. Pablo, I wanted to mention
that with over 100 students that you have on bioethics, are you teaching them or talking about how to incorporate AI into this? Yes, we are constantly renovating our curricula with all the red tape that this entails to incorporate all these evolution and advancements, because these issues have appeared not long ago. And Of course, we talk about the ethical use of AI applied to medicine. This is a world where we are still toddlers, still learning on the actual practical uses that we could consider, and also what sort of ethical concerns this is generating. This is a field where we gotta learn an awful lot, and maybe the most important thing here is to be aware, ethically aware, to use it with the right criteria. Okay, Pablo, and doctors in your hospital, do you receive specific training on technological tools, or is it rather being based on a personal interest? Yes, there is some continuous formal training in the public health system devoted to the use of these new technologies, and we also have a specific group in La Paz Hospital, whereby we are developing some research projects and other activities to implement AI on our daily practice. For example, right now we are monitoring the consultation with AI to obtain a real-time clinical record, and also we're trying to develop a virtual assistant for travelers so that they can be guided on the needs on specific vaccinations requiring a more complex, like yellow fever, for example, to define whether they are necessary or not, to filter and do the triage, whether they need to go to a specific doctor or consultation, to see whether they actually need to come or everything can be done with a family doctor. Now we're developing a project with the University of Rioja and see with some different stakeholders to define use cases that can be defined or broadened, and this context adaptation of different cultures and patients and scenarios. It could be an interesting Diego, I was wondering whether the Ramon y Cajal Hospital, you are also implementing or offering some sort of training on multiculturalities or the adaptation to different contexts in Latin America. Yes, surely this multicultural aspect has not been really thought about. Maybe we should be focusing on continuous training. They are not compulsory, so each professional, each expert decides. For example, in our service, we have a consultation on high-risk patient vaccinations. Sometimes we receive patients coming from Entre Culturas, the NGO. And in such cases, for example, yes, of course, I need to adapt and learn on those different cultural elements. So, yes, we have continuous training. And you mentioned the recommendations of consultations. We have an app that helps guide a patient as to which vaccines are necessary to make sure that the vaccination calendar is correct with the tools we have with our vaccines. And trying to answer to your query, I guess, yes, we need to regulate this training a little bit more so that health professionals are all updated, because we have a context where initiatives are being developed. But of course, it depends on their profiles and the possibility that each group has. Sometimes it could create inequalities as to accessing knowledge. And this shouldn't happen amongst professionals. Right, some more last-minute questions. Okay, I'll give you a further minute to each of you if you would like to add some some words for posterity. Anna. Right, as a conclusion, I would like to say that this whole digital revolution that we are witnessing is something that is truly helping us. It's very, very useful, but we need to be cautious, and we need to do an ethical use so that it's truly useful and not the opposite. As Anna has used only 30 seconds, you can do a minute and a half. Well, I'll only say that as for digital health and our development plans, generally speaking, obviously it should be incorporated in every single policy framework anywhere in Europe and Latin America. Thank you. Diego. I'd simply like to add that as these different panelists have in common the role that the digital tools play in the health sector and the need to establish these bridges and synergies amongst different professionals. We need to advance, but not quickly. We got to advance together because we're going to go far, far away if we collaborate together and enjoy all these amazing opportunities like this forum. I didn't know the guest speakers, and then you realize that each of us are complementary. We are experts and we can help each other. Pablo. I would love to congratulate Digital Europe and the rest of organizers for having organized this roundtable so that we've been able to talk about these current issues and the technologies that we have available, especially from these four perspectives: patient, anything dealing with society and public health, the technical pillar, of course, supporting us, but never forgetting the human aspect. Every single fact that we can use these technologies, but they will always affect our patient, and they should remain at the core of everything we do. Well, thank you very much. A very heartfelt thank you to Ana María Núñez Rubines from the official School of Psychologists of Galicia and UNIR, Mr. Antonio Zimorra, Director of Commissions at ANETIC and ALETI, Mr. Diego San Jose Saras from the Ramón y Cajal Hospital and UNIR, and Mr. Pablo Barreiro from the University Hospital of La Paz and UNIR here in Madrid. Thank you very much. A big round of applause. Thank you.